There you go. And so let's just introduce Rachel Levy, a core member of Rethinking Psychiatry, and also a social worker and somebody who is involved with the Lines for Life, and is going to talk to us about the real meaning of trauma-informed care.
Yes.
So thank you.
Thank you. I'm not sure how well this microphone's working. Can everyone hear me? Yes, my name is Rachel Levy. I am a social worker. I've worked in community mental health. I've worked in crisis support. I work for Lines for Life, which is we're the state chapter of the National Suicide Lifeline, and we also provide crisis phone coverage for some other agencies. And they are really trying to become a more trauma-informed workplace, so we'll talk about that some. And I've actually been here in this building this week for the intentional peer support training. Lines for Life sent several of us here. And appropriately enough, today's topic was taking a trauma-informed approach. The idea of holding multiple truths is something that came out of intentional peer support. It's a specific model of peer support that is very much based on connecting and not pathologizing. When you're taking a walk or going down to the bathrooms, you might see some signs that say things that sound really not trauma-informed. If you saw any of those signs that said things like, you're manipulating me, or things like that, that is definitely not an endorsement. Those were examples of language not to use and something we talked about today. So a lot of the stuff around the room is from today's intentional peer support training. So, I wanted to first find out how many people had heard the term trauma-informed care before they came here. Great, so it sounds like most people had. Oh, and one other thing we wanted to mention was I know there have been fears of the coronavirus. We talked about even possibly postponing or canceling the event. We decided not to do that, but I know that's a fear a lot of people have, and I have some trauma around family members with medical issues, so I certainly understand. We're just taking every precaution we can, but we decided to still hold the event. So I know it's a scary time for a lot of reasons, including that.
We invite people to cough into your sleeve. That's actually the material desiccates the buzzies, which is why it's better than just coughing onto your hand or sneezing. So we promised the person most concerned that we would make that plug. So yes. Thank you.
Yes. And I should also say we'll be talking some about different kinds of trauma, but not anything specific in any kind of detail, both in the interest of time and because that can be re-triggering or re-traumatizing or traumatizing for people. So we'll be talking about trauma in a very general sense. I have a couple of videos. None of them are really graphic. One has some kind of disturbing images, but they're fairly quick. And if you are feeling triggered for any reason, please take care of yourself. If you need to get up and go, feel free to. If you need to talk to someone afterwards, we've got the that's why we have, part of why we have the warm line and the lifeline. And my workplace also has a youth line. I know Sharon said that the warm line is only for people 18 and over, so my workplace also has a youth line, which we have cards here too. So I wanted to just get an idea of kind of what comes to people's minds when they hear the term trauma-informed care. So if you want to just shout out whatever comes to mind. I've got this attached to me because I'm recording, and thank you to my partner Jeremy for setting that up.
I think of going slow and having humility, because it could be so different for so many people and so different from what we might assume.
Yes. So going slow, having humility, understanding that trauma-informed care can look very different to different people. Yes. Yeah, so gentleness, being non-judgmental, allowing for vulnerability, creating safety. I think you said trust. Yes, not forcing it. Yes. Did I see another hand? Well, great answers, and we can certainly add more as the night goes on. I first heard the term trauma-informed care a little over a decade ago, shortly after I graduated from a Master of Social Work program. The place I was working at the time kind of threw around, we're a trauma-informed system of care, but it was never really explained what that meant, and it was kind of like based on what. And the kind of the good news and the bad news is that anyone can call themselves trauma-informed. I say the good news and the bad news because an agency can create their own ideas of what that means and individualize it. The bad news is because, it doesn't necessarily have to really mean anything. And the purpose of this isn't for me to say that I am, the perfect expert on what trauma-informed care is, but just to be kind of open a dialogue of what trauma-informed care truly means. And it doesn't mean that anyone ever gets this completely perfect, of course. So I just want to start with the official definition of trauma, not because I think this is a perfect, great definition, but this is kind of the official definition that we have to work with in the system, which is that PTSD, post-traumatic stress disorder, which was a diagnosis introduced in 1994, states that a person must, I don't care for the term must, have experienced or witnessed an event or events that involved actual or threatened death or serious injury or a threat to the physical integrity of self or others, and which involved fear, helplessness, or horror. It is a really well-written book, and it's a book that many people recommend, and I thought it had a lot of great points, and the author, Dr. Bessel van der Kolk, is pretty critical of the system. Unfortunately, the author, Dr. Bessel van der Kolk, about 2 years ago, ended up being fired from his job as the director of this trauma center that he helped found in Boston because there were allegations that he was berating and screaming at his employees, which was really discouraging to hear, and it kind of goes to show that you can be really trauma-informed in some ways and then not in others. He really is considered a leading expert on trauma. However, something was clearly going on with him that was leading him to create an environment that was the opposite of trauma-informed. And we'll talk more about kind of what that means. This is kind of, yes, I agree. Yes, I definitely noticed that too. It was very much stressing physical safety, which of course trauma can certainly be a big element of trauma, but it doesn't have to be. There are a lot of traumatic events that would not necessarily fit this definition. Yes, and there is an idea of post-traumatic growth. I know Molly mentioned in Reimagining Recovery, which is a controversial idea, and people have mixed feelings about it. We can get into that a little bit later. Yes, absolutely. There are lots of things. Yes, for example, somebody is kicked out of their home for being transgender. That is a trauma, regardless of whether it involves a physical injury or not. That's just one of many examples. Yes. And trauma is hard to define. This is one official definition of trauma-informed care, which is also hard to define, but exactly. And in this intentional peer support training, they're really talking about kind of shifting that paradigm from being about I am helping you, I am empowering you, to a more mutual and collaborative relationship. It's really hard, though, because this is kind of the dominant paradigm. And that's part of that holding multiple truths. Consumers isn't the term that I prefer either. Some people really like the term consumers. With survivors, I know that survivor is considered generally more of an accepted term than victim, but I've heard some people who prefer to say victim rather than survivor. So it's kind of the honoring multiple truths and different people have different preferences of what language works for them. Yes? Yes. It's certainly people should have safety in their workplace, but that doesn't mean not having difficult conversations, not having someone bring up something that's difficult or upsetting. Yes. And as a provider, I can say unfortunately, there's often a ton of stigma around admitting that you're struggling yourself. I feel like where I work is much better about that than most places. It's much more accepted to admit if you're struggling, but I couldn't tell you how many calls I've gotten from people who work in the medical or social service or mental health field who are struggling and are really afraid of their coworkers finding out, and sometimes go to great lengths to hide or travel really far away to seek treatment because of the shame and stigma. I think that's changing some, but it's still very true. Yes. Exactly, and yes, and social work has really, I think, gotten away from its roots. It used, not that it was ever perfect, but it became kind of, the profession of social work became more and more professionalized, and then there became more and more of a class divide, and that can be really harmful. And yes, absolutely. There, unfortunately, is a lot of us versus them, or us and them, or worse, us versus them mentality in medical settings, social work, mental health, rather than we're all in this together. That is something I really like about intentional peer support. Yes.
So just also the trauma that the capitalist
Yes.
context system inflicts.
Absolutely.
Usually the frontline workers being paid close to minimum
Yes.
wage, having impossible
Yes.
amounts of work to do,
Yes.
having a very punitive system that if somebody, I remember when I worked in, they don't even call it mental health anymore, let alone emotional health, they call it behavioral health now. And I remember I had a client, I was working in a system where I had a client who was very suicidal, and I remember one day getting a call that she said, I'm going to do it. It was overnight. I came in to this call, and she didn't, but that's the message that she left. And I realized at one point I have to get out of this system, because my first thought, and I cared about this woman deeply, but my first thought was, is all my paperwork in order? I'm going to get in so much trouble if all the T's aren't crossed and the I's aren't dotted. And I thought, this is not a system that is for people to be caring about anybody. And that was only after 5 months.
Yes.
So.
Yes, I definitely know what you mean. I have a friend who works in social work back east, and she had a client who did die by suicide, and her workplace poured over her paperwork and, made sure, they did tell her, we decided this wasn't your fault, basically. Your paperwork was up to par, but there was never any, are you okay? There was never any checking in with her about, are you okay with it? Or, what can we do to help and support you? And unfortunately, the system is re-traumatizing for people who work in it, as well as for people who receive services in so many ways.
So many ways.
Yes. Yes, thank you. And a word that gets tossed around a lot is evidence-based. And as far as whether trauma-informed care should be evidence-based, yes and no. We should certainly look at the research on what seems to be helpful and what seems to work best. However, we should also look at the research with a really critical eye. Came across an article recently. Actually, I came across 2 articles. There was also another one in Mad in America, which is a great site, that talked about this acronym, which I'd never heard, that most research is, quote, weird, Western. I would have thought the W stood for white, and it certainly could have. Educated, industrialized, rich, and from democratic countries. Of course, that's debatable. Whether, there's been this kind of long-standing trend of doing research on mostly white people. Mostly college students are by far the most studied people probably on Earth, and then the findings are just kind of generalized to everyone. And yes.
Even what questions get asked and researched.
Yes.
Is a huge skew. So just because you're studying drugs or a manualized way of doing therapy and not studying the other things, you're going to find that those are the things that get to be evidence-based.
Exactly.
But you're not studying these other things. Maybe they don't make money for drug companies. Maybe they're not able to be easily manualized. So it's a very biased system in many ways.
Yes, there's also a great book, Psychiatry Under the Influence by Robert Whitaker, that talks a lot about the conflicts of interest in research and kind of the cherry picking of studies that fit what people want to believe. So evidence-based is a term we should take really with a grain of salt. I think often the terms trauma-informed and evidence-based are kind of used hand in hand. Yes, and then it's like circular reasoning. And there's actually overwhelming evidence that cognitive behavioral therapy is not effective for people with, especially with severe trauma or complex childhood trauma, that much more physical and somatic treatments are much more effective. But the powers that be can say, oh, this is the only evidence-based treatment and this is the only treatment we'll provide. And then, and then you're like, exactly. Yes, and I'll talk a little bit more about that. Exactly, and then it's like kind of a self-fulfilling prophecy. Exactly, it can be very gaslighting. I know some people here were at the talk we did on the two-part talk we did, one or both of the two-part talk we did on gaslighting. Which does anyone want to kind of explain the term gaslighting? I can explain. We had a talk and we also showed the old film Gaslight, and the term was inspired by a film from the early 40s where this woman marries this guy who seems very charming and seems like the marriage is great, but then he's kind of playing mind games with her and he's basically playing tricks on her and basically telling her that her perceptions are not accurate, that she's imagining things, she's seeing things. So, and he does something with this, they have this old-fashioned gaslight that he kind of plays these mind tricks on her with. So gaslighting is kind of an abusive tactic of basically telling someone that their perceptions of reality are not accurate. So doing something that's actually incredibly disempowering and taking away someone's choice and triggering old traumas or new or recent traumas and then saying, oh, actually, but we're trauma-informed. We said we're trauma-informed. That could definitely be a form of gaslighting, absolutely. Yes. Yeah, and it sounds like a lot of people have experienced this in the system. It's just kind of trying to fix the symptoms without looking at what's going on underneath. And like, I think it was Kathy, whoever said it's about what happened to you rather than what's wrong with you. And a lot of times, a truly trauma-informed system looks at the different levels of trauma. There's systemic oppression, historical trauma, which I have a video about which will explain a little bit more about that. Intergenerational trauma, that's kind of more looking at trauma within a family. Vicarious secondary trauma, that happens a lot with medical providers, people who work in the mental health, witnessing trauma, hearing about trauma. ACEs, adverse childhood experiences, which we'll talk a little bit about more. Many kinds of trauma are not even recognized, frequently are not recognized or labeled as trauma. For example, a lot of people who go through serious medical issues are very traumatized by it, and that's not really recognized. Or, for example, I have a friend who has a medically fragile special needs child, and she posted a study of mothers of medically fragile children who talked about how they, after their kids had major medical emergencies, They didn't feel like anyone was checking in with them or even acknowledging how traumatic this was for them. So there are a lot of different kinds of trauma that aren't even often recognized or acknowledged as trauma. Any thoughts on this? Yes, the book, The Body Keeps the Score, talks a lot about that. How often people don't even have clear memories of the trauma, or they're very stuck in what has happened and just feeling frozen and paralyzed. Yes. And these are kind of some elements of trauma-informed care. It's accessible to all, recognizes the historical and social context of trauma, comes from a social justice perspective, provides a balance of structure and flexibility, because structure can be very healing, but also have to really individualize it. Fosters resilience, but avoids toxic positivity. And by that, somebody had brought up the term post-traumatic growth, and that's kind of a controversial term. Even talking about, there's also, people will often talk about resilience. Does anyone want to explain what toxic positivity is? Yes, because we don't know everything's going to be okay. Exactly. Or trying to find the silver lining in everything. Not everything has a silver lining. I read about this. I don't think the book used the term toxic positivity, but there's a book called Bright-Sided by Barbara Ehrenreich, and she's a cancer survivor, and she talks about how she found this a lot in the cancer survivor community, like that it was all about being so proud of being a survivor, which is great, but not. There was a real silence around even acknowledging how traumatic it was to have cancer, or to acknowledge any of the anything remotely controversial or political about it, like carcinogens in the environment or lack of access to health care, or just to acknowledge how scary and traumatic it was. So resilience, definitely focusing on resilience is important. Post-traumatic growth is the idea that sometimes people can develop skills or can become more mature or more compassionate or more insightful from their trauma. However, that term should be used very, very cautiously, because it can potentially come across as minimizing or as toxic positivity. And I did a little bit of research on kind of what's going on with trauma-informed care on like the federal level. There was this act in 2019. It was inspired by the Kaiser ACEs study. I know somebody mentioned Kaiser not being exactly the most trauma-informed system. The ACEs study was a partnership between Kaiser and the Centers for Disease Control, and it asked people about their adverse childhood experiences, if they'd been abused in childhood, if they'd had someone close to them die, if they'd had someone close to them in prison, someone close to them addicted to drugs or alcohol. And there's a 10-point, I think it's 10 points. I think 10 is the maximum you can have, if I remember correctly. And they did studies correlating people's ACEs score. Of course, the idea of putting a numerical score on someone's trauma is a bit problematic in a way, but they did these studies showing just huge correlations between pretty much any kind of mental health struggle you can find and physical issues. I think there was like a 5,000%. I think like somebody with I don't remember the exact numbers, but I know like with suicide attempts, there was a huge correlation with somebody's ACE score and the likelihood of them attempting suicide. Heart disease, asthma, pretty much diabetes, addiction, violent behavior, ending up in jail. Anything you can think of, there was a very strong correlation. Yes? there is something that feels problematic about that. On the other hand, it did really show that there is a huge connection between childhood trauma and health issues. It has kind of helped support funding for certain programs, so I have really mixed feelings about it.
To me, it was a really radical thing that people were actually looking at a lot of things that were even systemic, like poverty and things like that,
Right.
and putting those things into the picture. So they weren't like asking people to rank things. They were just saying, have you experienced this? And if you have, you get, it's like, let's just count how many really big, horrific things that you as a kid had to deal with, just to be able to see, does that even have common sense? We know that has an effect, but in dominant culture, it was not at all recognized. So it was really breakthrough.
Yes, exactly. So yes, and it did kind of confirm what a lot of people thought about the correlation between childhood trauma and both mental health challenges and medical issues. And so
it worked as an antidote to victim blaming. I think that's a huge piece about it.
Exactly.
It's not like, you don't have a healthy lifestyle, you're not exercising enough, you don't care enough about your health. It's like, actually, let's see this bigger picture.
And it also showed how incredibly common childhood trauma was across and I think the studies have been replicated. The original study, I think, was pretty much focused on mostly middle class, mostly white people. I know there have been other studies since then, but it did show how incredibly common these events are. And this act kind of seems like, at best, a Band-Aid approach. It does increase some funding and support for some programs that might be helpful for people with trauma. However, there's a whole lot that's not being addressed. There's a lot that's extremely traumatizing in our system. As Cindy mentioned, I know some people mentioned how traumatizing our system is, and in a way it kind of feels absurd when when our government is tearing kids from their parents and putting them in cages, and when our whole system on so many levels is so traumatizing. This seems like kind of, there are certainly positive aspects to it, but it also kind of seems like a Band-Aid approach. I wonder if it's the same lady. I have a video that I'll show in a little bit on I think her name is Dr. Joyce DeGroy. Yes, and she talks about
PSU professor.
Oh, okay.
So there's the historical and intergenerational trauma. There's a lot of overlap with that, and the original research that was done by a woman named Rachel Yehuda, and she was looking at children of Holocaust survivors and seeing a lot of the same trauma responses, even though the kids grew up here and never experienced the Holocaust.
Yes.
She had a research assistant named Maria Yellowhorse Braveheart, maybe? I can't remember anymore, but who said, wow, this would be really useful in my people's experiences in communities. So she took it into Indian country and created all kinds of amazing tools with that. And then Dr. DeGroy,
yes.
I don't know how to say her name. I think it might be French. I can't pronounce French. Anyway, and she said, wow, this is really useful in my people's community, and she wrote a book coined a term called post-traumatic slave syndrome, and looking at how a lot of ways that African-American parents get blamed when it's really survival strategies that have come down from slavery and Jim Crow times and gets passed down. And so a lot of, and I'm sure in every other people's communities, people can
see how it works too.
Yes, and yes, I've got a video about that. SAMHSA, which is the Substance Abuse and Mental Health Administration, has been doing some work on acknowledging trauma, creating more, creating guidelines for trauma-informed systems, looking at looking at the events that have happened, the effects that the person is having, their experiences. And these are some guidelines that SAMHSA has created for trauma-informed care, which is realize the impact of trauma, recognize the effects, respond in a respectful and caring way, and resist re-traumatization, kind of like what Kit was talking about. I know what several people have mentioned. Re-traumatization, the system can be very re-traumatizing especially when people are forced into treatment, when police are called, when DHS becomes involved. Re-traumatizing means, for example, if a person experienced abuse in childhood, so they were not given choices, they had something really scary happen to them, and let's say, for example, somebody calls a crisis line, they're an abuse survivor, they're really struggling with PTSD, having suicidal thoughts, and let's say that the crisis worker calls the police on them. In my work, we try very hard to avoid that. We really try to work with the person and really treat calling police as the very last resort because it is traumatic. So, but say police are called and the police come banging on the door, and maybe there's this big police officer that looks like the person's father who was abusive to them, and they're reminded of traumatic events that happened when they were a kid and were being abused, and then that kind of brings up a whole lot of trauma in a way that's what we would call re-traumatizing. Yes, exactly, and that's even in the best case scenario if they're not blatantly abusing their power, which of course we know what happens all the time. I know a lot of people are afraid to call a crisis line or afraid to admit if they're having thoughts of hurting themselves and or other people because they're afraid of police being called. I can't speak for other crisis lines. I can say honestly at Lines for Life we really do try to do everything we possibly can and to avoid having to call police and to work with the person collaboratively, because I honestly hate calling police for that reason as well. Yes, good point. It's more the approach. Yes, good point. Yeah, the earth is being violated. Yeah, it's on a larger scale. And yes, and often people who do awful abusive things have their own trauma. Not that excuses it, but
right,
but
it's
it's
I mean,
yeah.
look now, someone who's just ripping children out of the arms.
Right.
What's operating, and
Right.
he's not the only one because it takes a whole group of folks to
Right.
do this. So there's some serious ACE scores that we're not looking at
Exactly.
that need to be addressed.
Exactly, and there often is that whole cycle. Yes.
So not
Yes,
just looking at the ACE scores of the people who are the victims, but also the people who are the perpetrators.
Yes,
Wow.
yes. Yeah, no, Dr. Bessel van der Kolk talks about that some in his book, and yes, absolutely, that's a tough thing to reconcile. It's a complicated one. Thank you so much, everyone, for your...
Dr.
Yeah.
Bessel van der Kolk also has...
Exactly, and then he treated his employees really badly. So yes, it's very complicated. I just wanted to end this part with this quote from Maya Angelou, who was herself a survivor of pretty horrific childhood trauma, and she says, "History, despite its retching pain, cannot be unlived, but if faced with courage, need not be lived again." And it is a hard thing to hear. Yes. We've been talking a lot in the intentional peer support training about just how complex human interaction is and how easy it is to be misunderstood or to disconnect from people. Mm-hmm. Right. Yeah, the idea of, yes, sometimes, and some people might have trauma around being expected to be perfect. So I really liked what she said about, like, you don't have to be perfect. We are going to make mistakes, but it's about doing our best and acknowledging if we make mistakes. Exactly. Thank you. And thank you, everyone. There's also Trauma Informed Oregon has some good sites. I feel like I was kind of reintroduced to the concept of trauma-informed care from them. I kind of, for a long time, I kind of felt like that was just like a meaningless buzzword that was being thrown around a lot. But Trauma Informed Oregon, I think, has a lot of really, really good, helpful information on their website. I also, my mom actually did a training. My mom works for a state anti-sexual assault coalition in Washington, and she did a training on trauma-informed care, and she made some resources which she had sent to me, so I printed it out. I did, yes. So and
Rethinking Psychiatry at gmail.com.
Yes. So if you're looking for any further information, feel free to email us. Thank you so much for everyone. Great talk and discussion, and I would encourage you to